this out of focus for you? Let's see if we can get it clearer. If you can't see, and even if you can, or don't even wear glasses, this video is for you. We're discussing a case of a patient that we saw around 2018 this time, and then again in 2019. We've written the result down so that it's easier for everybody to understand. The patient in question is a 28-year-old male who presented to the practice for the first time in 2018. He is a myope, meaning that he's short-sighted, and this was his first pair of glasses. So he was a minus 1.25 in the right eye with a bit of astigmatism, and a minus 1 in the left eye with a bit of astigmatism there as well. We saw slight, and when I say slight, I really mean slight, where you're kind of so doubtful if you should refer or not, slight signs of something called keratoconus, which we're going to get into. So we asked him to return to the practice, although we obviously made him glasses. We asked him to return to the practice in 2019. We had a slight increase in prescription, so we got to 0.50 more in each eye, a 1.75 there, and a minus 150 there, with the same amount of astigmatism. And we saw the signs again. Nonetheless, though, in terms of his refraction, we had an increase in refraction within a year on a 28-year-old. However, when we put that prescription into a trial frame for comfort, we found that the prescription we need to prescribe is exactly the same as his glasses. So no new glasses were made. However, the technique that I just showed you now, called retinoscopy, probably saved his vision for the rest of his life. The reason is because we saw signs of something called keratoconus, which led us to believe that he needs to be referred to an ophthalmologist for a scan. So, normally what happens in practice, you have an auto-refractor done. So you sit behind a little machine and look at a house, and it gives us a printout of what your prescription is, more or less, and also importantly shows us the readings of your cornea, or how curved or flat your cornea is. Then what happens is the optom sometimes takes that result and plugs it into the phoropter and starts the eye test from there. However, in our practice, what we do is, although we take the autorefractor reading, each and every patient has their eye test started from scratch, where we do the retinoscopy technique. How the technique works is, there's a light inside your pupil, and then we compare that to our retinoscopy light. If it moves in the same direction, we add a plus lens. And opposite direction means you add a minus lens. What you've got to look out for is if it splits like a scissor. In this patient's case, in 2018, we saw a scissor reflex. When he came back in 2019, we had the increase in prescription. So despite the fact that he was still comfortable on the previous script, we still had an increase in a 28-year-old, and we had a scissor reflex. And to add to that, we had what's called an oil droplet. So it's when you use this little guy, it's an ophthalmoscope, you see a shadow at the bottom. Those indicate signs of keratoconus. I'm going to show you guys what keratoconus is. So, rather than a type of refraction saying that you can see far or can't see far, keratoconus is more of an eye disease. It affects your cornea. Your cornea is your transparent or clear layer over the colored part of your eye. A normal cornea is meant to be flat, steep and flat. And when you have keratoconus, your cornea keeps on getting steeper, and because of that keeps on getting thinner. Your surface of your eye is now very distorted. So light comes into a very distorted surface and doesn't allow you to see clearly. You would not necessarily normally suspect a short-sighted person of just randomly having keratoconus. However, because of the very important technique of retinoscopy, we picked up the keratoconus. Keratoconus is a disease that has 4 stages, 1, 2, 3, and 4. Besides the 4 stages, you also get a pre-keratoconus, what's known as Forme keratoconus. So it's the stage before it becomes keratoconus. It may or may not actually ever progress into keratoconus. So your cornea is there, and when you have a Forme keratoconus, The keratoconus, or the disease of the eye, as I'm referring to, sits at the back. So the clinical signs are very, very slight, very minimal. They're almost none, as in not there, or they're very slight, and it makes it one of those very doubtful cases like, should I refer? Am I going to waste my patient's money? Are they going to be upset with me? You know, it's one of those cases where you rather just refer it because rather be safe than sorry. So we referred this patient, if I haven't already mentioned, and guess what? He does in fact have what we termed Forme Fruste keratoconus, and we've obviously saved his vision because if the keratoconus is never picked up, eventually the cornea becomes so steep that it actually bursts, and then you need a graft. So somebody has to die, give you their cornea, and then you get rejections. Although obviously I don't want to make you scared, I just want to inform you, after rejections you eventually do get success with the corneal graft, but you want to pick it up early so they can do earlier, better treatments called cross-linking to link the cornea up again, reshape it, and put the disease into remission. So guys, it's extremely important to have your eyes tested, whether or not you think you can see, whether or not you wear glasses. Remember, kids need to be tested from as little as 5 years old every 6 months, and adults or people generally need to be tested every year, even if your insurance only covers an eye exam every 2 years. Please remember, optometrists are clinicians and not retail vendors. Please test your eyes in the time frame that's recommended by your eye care provider. If this video was informative, please hit the like button below and watch out for more videos.